We cannot hear. Okay.
Different.
We come to second room. John, we see you now.
Yeah, we're ready.
Okay, could you present the case?
Can you hear us?
Yes. Yes, clear.
Yes. You can present the case?
Yeah. So this is a 54-year-old gentleman, non-diabetic, non-hypertensive, smoker. He's had a primary PCI to RCA in 2013 and treated for his in-stent stenosis again in 2016. Now he's come with class 2 angina. Thallium was positive in the anterior wall. He has EF of 45%. He has ECG from the inferior wall, the suggestive inferior wall MI. And this is the angiogram which we are showing you now.
So the control on the right coronary artery was normal.
Yeah.
And this is what we have taken a few minutes ago. So you could see that there is a left main, not only distal, but the lesion starts at the mid portion of the shaft of the left main. This left main gives a LAD, which is a 3.5 millimeter vessel in proximal, and a circumflex, which gives a distal circumflex, and a large OM branch. So when you look in the spider view, you could see the left main, which is a large left main. It's at least 4.5 millimeter, certainly a 5 millimeter left main. So I think that we will need a 5 millimeter balloon to finish. Then you could see here the LAD on the left and the circumflex on the right. When you look at and this is certainly the best view in the aerial-cranial, you could see
Pericular
here
tight stenosis.
the critical lesion on the left main and involving the ostium of the LAD. I think that, can you see it?
Yeah, it's clear.
Okay, clear. Okay, so that's a really true bifurcation. It's true that the ostium of the circumflex is not severely diseased, but the lesion is so severe that we can anticipate that after placing a balloon or a stent in the left main LAD, that will be, the LCX will be pinched. The second point is that we have some disease in the circumflex artery. You could see here, and we can see again on the previous view, on this one. Sorry. The next one. Here, what we have done, it's just to measure the length with the tip of the wire, of the BMW wire. And you could see that this is 30 millimeter. This is 30 millimeter, and I think what we will need is at least a 23 millimeter stent, certainly a 3.5/23, and then we will start from the mid portion of the left main to the proximal LAD, and we will post-dilate with a 4.5. So the goal today is to show, the objective is to show how to perform a stenting of this kind of distal left main lesion. Certainly, we discuss in the room, because there is a lesion on the left circumflex artery on the OM branch, we will plan to have a two-stent strategy. So there are two possibilities. We could use a culotte technique because the diameter of the LAD is quite similar to the diameter of the OM branch. It's around 3.5. So this could be done with a culotte. The other possibility is to use a tap technique and with the left main LAD, and then after doing the pot, we will recross. So now I think we will do the pots. We are in the view cranial, aerial-cranial. So what we will do is to place with the first wire, so test, in the distal LAD.
John?
Give me the second wire.
John,
Yes.
this is a discrepancy between the proximal LAD and left main, maybe 3.0 and 4.45 in the left main. And as I know, there is an ongoing clinical trial
I think that should be
on the
close to 5.
stentist left main, the dedicated
it's okay.
stentist.
Yeah, but with the new, the last generation of stent, a 3.5 millimeter stent can go up to
Can up-
4.55.
upsize.
So this is not a
Upsize,
major problem. Okay, so what we can do is to, we can work on the same view, ready to test, and advance a second wire test. I'm not in, huh? Sorry. Okay, test here. Interesting. So if I cannot do that, we can take the AP view. Okay.
You are still busy with your technique. May I ask our panel, Dr. Wong, will you prefer to stent technique or some other different technique?
I will probably do a provisional one because the thallium scan show that the ischemia in the interior. I'm not so sure whether the circumflex OM branches is ischemia. So since the ostium of the circ is not that disease, I'll do a provisional stenting for this case. Yeah.
Ran?
So we can we have an epicodal, please?
I agree with what Dr.
Epicodal,
Fajadet
please.
explained. There are many different ways to treat. If you treat
Epicodal.
with planned upfront to stent techniques, I think both culotte and crush depends what is your experience and preference. But I'm following the school to start stenting of the most severe lesion first, which is definitely distal left main ostial LAD. So I would do exactly what Jean explained.
Okay.
Start as a provisional, but then reevaluate and then
Give me the balloon,
probably
please.
do tap
3-0.
stenting for marginal branch.
So now we have placed the wire. Thank you. I agree, Goran, with your comments. And so what we have done, we have placed the two wires, one in the distal LAD, the other one in the distal OM. Give me the balloon.
Yep.
Quickly. Oh, there is something wrong. The balloon cannot be advanced. Give me some fluid. Okay. Take care. Take care of this because if not, we'll have some mistakes. Now remove the balloon. I don't know what this balloon is stuck on the wire. Give me the wire again. The balloon again. Sorry for that.
In case like this, is the IVAS or OCT will help you or guide you to a more
there is a problem with the
appropriate
balloon.
procedure? John?
I'm sorry. So sorry, I cannot hear you. The sound is too high. Can we reduce the sound, the volume of the sound, please?
Will you do IVAS or OCT to guide
Give me a 3.5 balloon. A 3.5 balloon.
Yeah, yeah.
Now give me this balloon out. So sorry for that. What is this balloon? It's a...
312.
312?
Yeah.
Okay, so it's a 3.0 12 millimeter balloon. We will first inflate the balloon in the LAD.
Left main LAD.
LAD first.
LAD.
Where are you? Test, please. Test.
Yeah, it's cross.
Test.
That's still in the
Okay,
left main.
here. Test. Okay, go on.
Yeah.
6,
Going up.
8. So balloon in left main LAD is the 3-0, go to 16, 18. 18 atmosphere, pressure down. And now we will advance 3-5 by, so we hesitate between a 23 or 28. I think it's not necessary to
No, they are 3.5.
to go to
23, 28,
the osteum.
3.5.
I think it's not necessary. Take care of the balloon. Take care of the balloon, please. And read it for the control. Control.
I agree,
Go on.
Jean, with you. It's really long left main. The ostium does not seem to be diseased, so it's better not to stand up to the ostium.
Yeah. So give me this view, please. Dario, Cranio.
Cranio
And
one.
give me 3.523. Alpine 3.523. Open the stand. So we take a 3.523. Then we do the pots with a 4.5 millimeter balloon. And after that, we will recross the struts, open with a 3 millimeter balloon, and descend the stent which will be certainly a 3.5 in the circumflex OM. After that, we will certainly do the kissing, and maybe we will finish by the final part. We will see. So here we are in the LED. This is a stent center, table 3, please. Okay, here. Can we make a shield, the filter on the side? Thank you. So this is a stent. I think it's enough. We can remove the wire a little bit. It's too distal in the LED. Test. Go on.
Close. Yeah.
I think it's not too bad here.
Wanna go?
Yeah, go on. 6.
Resistor. No?
Inflation. 6. 8. 10. 12.
12,
14.
14.
16.
Distal one still not yet.
Go to 18.
18.
Pressure down. Pressure down. Pressure down.
Yeah. Okay.
Yeah. We have ST elevation immediately in on the ECG. And now what we will do is to take a view and certainly
Five alalo.
to take a
What?
4.0 and then a 4.5 because
4.5? 4.5?
attends, no, the balloon.
Yeah,
The balloon. Take
yeah.
a picture. First,
4.5.
no. First, take a picture. Step by step, okay?
Yeah.
Picture first. Go on. Okay, so now we have to look at the result. It's not too bad. Give me a 4.0 now. 4.0, it could be NC balloon.
Yeah, 15.
It could be a short one. It could be a long one. 12, 15 is good. 15 is okay. Okay, take care of that.
Yeah.
The balloon here. Okay.
Jean, do you think the distal segment of the stent should also be post-dilated? It seems that balloon was not really completely
Yeah, so
open.
I will post-dilate with a 4.0,
Okay.
high pressure, and then we will take a 4.5 for the proximal part of the stent. But I think that the 3.5 balloon was not optimally open. So
Yeah.
this one is the NC balloon. So with the NC balloon 4.0, we will go up to 20, 22, 20, up to 25. And I hope that the lesion could be open. So here we are. I will not too distal. I don't want to place the balloon distal to the
Yeah,
stent.
it's
Here is
fine.
okay.
Yeah.
Go on. And here you take 20. 20 atmosphere with the 4.0.
18, 20.
20, 22, 24. I think now it's open. You see it?
Yeah, now it's open, yes.
The shape of the balloon is correct. Okay, stop. And now give me the 4.5. Yeah, 4.5 now. 4.510, no problem. It could be a short one. Take care of the wire during the manipulation, and because sometimes we could be traumatic, you know, with the distality of the wire, okay? And give me something to flush the wire systematically after all the manipulation, you see? Give me some water, okay. Okay, 4.5. So maybe we can, I can show you the last balloon inflation. It was a 4.0.
Would you like to remove the
Full
circumflex
wire.
wire and rewire it before
Full
you
wire.
inflate again, or you would like to do the pot first and then remove the
No,
wire?
no, 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 no. We will take care of fix we will leave the wire of the circumflex jailed even after,
pressure.
during the pot. So now for the port, what we need is to place the distal marker just at the site of the bifurcation. Test, please. Do this, okay, here is not too bad, go on. And now with the 4.5, you inflate up to 18, 20.
16, 18.
Okay,
It's
stop.
close to 5 millimeters, yeah?
So have you the stand boost or
10 bush.
not? Just to see where is the proximal part of the stand. Could be more proximal. Here, go on. 6, 8, 10. Okay, stop. So now what we could do is to take a view to have the result of that. And then with the third wire, we will...
One new more wire, please.
Give me another BMW wire, please. Ready for the check?
Yeah. Anune?
Okay, go on, check. Ready? Very good. So you see now the left main is correctly open. The ostium of LED is it's open. There is a little step between the ostium and the proximal LED, but this is good. There is no dissection. And now the goal is to recross and place the wire. Okay, we have the wire, please?
Yeah, yeah.
So this is the jail wire, huh? Okay?
Yeah, this one.
So give me this flush. Yeah, and you need a lot of flush to flush all the flush. Please, the syringe with the water.
Yeah.
Dr. Tarakan,
Yeah, we have to flush all the needles, etc.
Tarakan, will you do IVAS or OCT in your left main case?
I think IVAS is better appreciable, so I would IVAS.
How about the stand bush? You panelists used anyway?
I have not the stand boost available in the lab. It should be very interesting in this particular case to see exactly the proximal and the distal age of the stent. But we will do without, no problem. So now advancing the third wire, it's the same wire, BMW wire. We are not seeing, okay, here we are. We are in the LED, you see? Yeah. Give me the talker. So you see, you saw that I advanced the wire with a loop, and this is, we are sure that we are in the right lumen, in the right channel. So now I pull back, take a little bit clockwise, test, and we will try to cross the struts. Test. If not, I will move to the other view. Normally, I'm working in the RAO or in the spider view, but in this particular case, it was very difficult to see it. That's the reason why we use exceptionally the RAO cranial view. So now, what we can do is to remove the gel wire. Okay, this is done. And now on this one, we can advance a 3 millimeter balloon. Okay?
3 balloon.
It could be 312, it could be 315, no problem. It's quite a long lesion. Huh?
Sean, is there any study when you use a stent small size and you overinflate up to 4.5, polymer peel off or polymer crack down? Is there any information about that?
No, for the 4.5, for the, again, with the last generation, the DES, a 3.5 can be open at 4.5. Over 5 millimeter, I cannot tell you yes, but 4.5, there is no problem. So this is a 3 millimeter balloon by 12. So we will do several inflation. The first one at the ostium, of course. First we have to open the struts. Then we will do the second one on the WAMD, okay?
Guiding.
You will stay in the same
Okay, here we
view?
are. Here we are through the,
Oh,
it's
right.
not too bad.
still in the
Go on,
strap.
inflation. We are through the threads.
Yeah.
8, 10, 12, 14, 16, 18. We have to open it, like wide day. Stop. Now we can advance again. Go on. 8, 10, 12. Keep quiet, sir. Everything should be finished in a few minutes. Stop. We advance a little bit more. Here, 6. 8, 10. Stop. One more time.
Which stent do you want?
8, 10.
Stent, which one?
10, 12, 14. Stop deflation.
Look, Kollam.
And now what we will do, one more inflation at the osteum to be sure that the stent will cross. Because there is a tortuosity, yes? So it's not easy. Okay, go on. 18. Stop. Pressure down. You can take the balloon. We will remove it. We will take the view now. We take an image of that. Ready? Take care of the lady wire. Take care, I will take the lady wire a little bit more distant. Okay. Picture?
This is a very nice demonstration. See how smooth you perform all the
Okay, so
left
now
main
what we have to do
bifurcation.
is
eh?
to advance. Yeah, now what we do is with the wire of the circumflex, I will measure the length.
The length,
What we
yeah.
need. Go on, picture. So this is
Right now.
30.
28.
Definitely it's more than 15. Maybe 20, 23 should be okay. What do you think? Yeah, because it's tortuous. I will prefer to do that. Give me a 23. It could be a 3-0. 3-0, 23.
323.
I view the 323. We can post delay it at 3.5 at the end, but
Yeah.
give me a 323. It should be easier.
Okay, Sean, we are coming
Okay,
back to
so
you.
we have just finished, and I can show you the final result. After nitroglycerin, the spasm distal to the stent disappear, and this is the final result. You could see that the left main was post-dilated at 4.78 millimeter. The proximal LAD was post-dilated at 4 millimeter, and it's 3.5 millimeter in the circumflex. And this is the final result in the RAO view. I can show you the result here in the spider view. And you can see the size of the stent compared to the size of the left main. I think the result is correct. What we can do is to do the last view.
Yeah, you want more?
Open. Caudal. Give me the caudal.
We missed
80
you
caudal.
when you implant the
Caudal,
circumflex
caudal.
stent. So which technique? T and protrusion or
A little bit RAO.
which technique?
This is a tap technique.
Tap
T and
technique.
Big shot. T and protrusion. And this is the final result of the T and protrusion. If you didn't see the tap, I will show you. You can come back. And because it's very important to see where is the placement of the stents. Here was the post-dilatation with the balloon more proximal, of course. And the tap was done at that point here. You see, this is the way to place the proximal marker of the stent between the two markers of the balloon left in the LAD, left main LAD. And this is the delivery. You see, this was the positioning of the stent with a little protrusion. Then we open the stent, and then I pull back the balloon inside the left main, and we took 21 atmospheres. You see that the proximal marker of the stent is more, of the balloon of the stent is more proximal because we are really inside the stent. And then we did the final kissing balloon with a 4, 5, and 3, 0, up to 20 atmospheres. And this is the final result.
That's
Okay, so
beautiful.
this is the way, which is a simple way to do a tap technique without imaging in this case, but by taking care of the, you know, of the size, the angiographic, by estimal visualization from the angiography, and we know that the LED was at least 3.5. We know that the circumflex was around between 3 and 3.5, and it's a reason why we know that at the beginning that the diameter of the stent will be a little bit more than 4.5, between 4.5850, and this is a final result.
Thank you.
Okay,
That's very,
simply,
very
without imaging,
beautiful.
but
Very
this is
beautiful. Very
possible too.
world-class experience on your left main
All right.
stenting. Thank
See
you
you.
very much.
Thank you, sir. Thank you. Thank
I
you,
would
all
like
the
to
team.
conclude our session